Let's talk about operative vaginal delivery background. It's about 3% of all deliveries. Choice of instruments. Vacuum can be applied when the head is asynclitic. Vaginal birth is more likely with forceps. Forceps associated with third and fourth degree. No difference in neonatal cephalohematomas. No difference in urinary incontinence or anal sphincter dysfunction after 5 years. Vacuum is discouraged less than 34 weeks. Techniques. Forceps for sagittal suture is aligned with the shanks. Posterior fontanelle is 1 finger breadth above the shanks. Lambdoid suture are equidistant from the forceps blades. For vacuum is 2 cm anterior to the posterior fontanelle and centered over the sagittal suture. Episiotomy not recommended routinely. Medial lateral episiotomy has lower risk of anal sphincter injury than midline episiotomy, but increased likelihood for long-term perineal pain and dyspareunia. Midline episiotomy increased risk for anal sphincter. So newborn complications. Intracranial hemorrhage, 1 out of 800 operative deliveries. Subdural hemorrhage is between the dura mater and arachnoid membrane. Dura mater and arachnoid membrane. These are asymptomatic until 1 to 2 days of life. The neonate will have seizures or respiratory depression. Mostly conservative treatment. Subarachnoid hemorrhage, similar presentation to subdural hemorrhage. Epidural hemorrhage is rare in neonates, but it can deteriorate quickly due to arterial bleed. Neurologic complications is 1 out of 300 operative deliveries. Neurologic complications, 1 out of 300. Intracranial hemorrhage, 1 out of 800. Vacuum is associated with cephalohematoma, subgaleal or intracranial hemorrhage, retinal hemorrhage, hyperbilirubinemia. Cephalohematomas is between the skull and the periosteum. About 1% of all deliveries, self-limiting, resolve over a few weeks. The baby is at increased risk for hyperbilirubinemia. Subgaleal hemorrhage is 6 out of 1,000 operative deliveries. Between the bleeding is between the periosteum and the aponeurosis of the skull. It's between the soft tissue. Therefore, it crosses the suture. It crosses the suture line. Therefore, there's potential for massive blood loss. It can extend all the way to the orbital ridge anteriorly. and the nape of the neck posteriorly and level of the ear laterally. There's a 15% mortality rate. Forceps, facial laceration, facial nerve palsy, corneal abrasion, external ocular trauma, skull fracture, intracranial hemorrhage. Fetal macrosomia, no difference in injury when compared with vaginal birth without operative deliveries. Maternal complications, 3rd and 4th degree laceration, 6 times the risk with forceps, 2 times the risk with vacuum. Risk of recurrent sphincter tear is 3% in subsequent births. Contraindications for operative deliveries, operative vaginal deliveries, unengaged head, unknown position, fetal bone mineral demineralization conditions such as osteogenesis imperfecta, bleeding disorder such as autoimmune thrombocytopenia, hemophilia, von Willebrand's disease, birth weight, and second stage labor duration were significantly associated with operative failures. Rate of failure is around 5%. So birth weight and second stage labor duration. Sequential use of different operative instrument is not recommended due to increased risk of neonatal complication and maternal complication. Release of vacuum pressure between contractions did not improve outcomes. 30% of neonates had cephalorhematomas after 5 minutes from application to delivery. So let's take a look again at the picture. So caput succedaneum. This is very benign. And then you have the cephalorhematomas. This is between the skull and the periosteum. Subgaleal hemorrhage is between the scalp and the periosteum. So the galea aponeurotica and the periosteum of the skull. And then you have the epidural hemorrhage, then subdural hemorrhage and subarachnoid hemorrhage.